Welcome to the Rocky Mountain MS Center's webinar series. This series is designed to give people with MS information to empower them to make the best choices for their lifelong brain health. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. This series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Our most recent videos are from the Conversations on MS series, which is a 90-minute town hall style Q&A with MS specialist neurologists and includes a clickable index of topics. You can join the next session live with Dr. Enrique Alvarez on August 18th, either online on Zoom or in person in Centennial, Colorado. We announce upcoming educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. Today's presentation will discuss sleep, MS, and your brain. Our presenter is Dr. Andrew Wolf. Dr. Wolf attended medical school at the University of Colorado Denver School of Medicine and completed residency and fellowships at the University of Colorado. His research interests are focused on improving the treatment of patients with multiple sclerosis and other inflammatory diseases of the central nervous system. Current projects include developing digital and blood biomarkers to detect worsening in multiple sclerosis patients, characterizing clinical outcomes of neuroinvasive West Nile virus infection in patients on anti-CD20 treatments, and understanding the risks of immune checkpoint inhibitor use in patients with neuroimmunological disease. He's also interested in the acute management of demyelinating diseases and optimizing inpatient to outpatient care transitions. This webinar features a lot of information. If you missed something on a slide or you want to hear it again, we are recording it and it will be archived on our website, mscenter.org, so that you can replay it at any time. All live viewers will get the recording automatically sent to them. You will also receive a link to our evaluation survey. Please take a few minutes to fill this out to help us improve future programming. We'll reserve time at the end to answer questions from the audience. You can submit your questions at any time using the Q&A box on Zoom. Today's presentation is for educational purposes only, and we are unable to answer questions that are very specific to your personal situation. All treatment discussions should be discussed with your own neurologist. With that, I'll turn it over to Dr. Wolf.
Okay, great. So thank you so much, Kelsey, and to the MS Center team for the introduction. I'm just going to pull up some slides here real quick. All right, and hopefully that is working okay. But my name is Andrew Wolf. I'm one of the neurologists specialized in MS and other inflammatory diseases of the brain and spinal cord and optic nerve here at the University of Colorado. There's about 10 or 11 of us, depending on who all you count, but certainly happy to be here and partnered with the work that we do with the Rocky Mountain MS Center. So our goal is to do a little bit of a whirlwind topic, talking about just an overview of sleep, how sleep is relevant to MS, and for people with sleep disorders who have MS, what sort of testing and then treatments and improved symptom management might be available. So just some disclosures. So a variety of funding for research and then some consulting. There's some additional links there just for more details, but nothing that is relevant to the content for the webinar today. So as far as an outline for things that we're going to talk about, so I'd like to just review some basics of sleep biology, just how our body sleeps, why, what parts of the brain are involved in that process. Discuss how sleep is important both for brain health and for overall health. I think this is increasingly recognized that sleep can be a very important component for things ranging all the way from things like memory disorders to MS to heart disease, for example. We'll talk about specifically some sleep disorders that are more common and actually quite common in patients who have multiple sclerosis. And we'll talk about how those disorders are diagnosed, and then how they are potentially treated, with a little bit of a focus on how I might manage some of these things in my clinic for patients with MS. And then we'll just talk about some more practical day-to-day tips about optimizing sleep and sort of getting to the bottom of sleep disorders. So I like this quote when I was pulling together some research and background. So this is from a sleep scientist named Alan Rechthofen. And so the quote was, "If sleep doesn't serve some vital function, it is the biggest mistake that evolution ever made." So just really meaning that we have so many processes that are geared for sleep in our body, that it must be really important. Although it is honestly still, to some degree, as we'll talk about, a mystery as to all the functions that sleep does and how it works. As far as what we have figured out as far as sleep, so this is from a paper from about a year ago that reviewed the importance of sleep function. So we think that sleep is a restorative state that can help with recovery of various body systems and sort of programming of things in a way that allows our body to be optimized during waking hours. And so that can involve a number of systems that are directly relevant to MS patients, including the brain and the immune system. But there are a number of other systems that may be less directly involved. And one topic that has gotten a lot of attention in neurology and neuroscience over the past, let's say, 10 to 15 years is sleep functioning to clear the brain of waste products, so especially in Alzheimer's disease, and this function called lymphatic clearance that you can see over in the figure under the green heading of brain functions, is that toxic proteins and other chemicals may be cleared from the brain predominantly during sleep. It's also felt, if we work down that graph, that sleep is important for helping sort of to consolidate or program memories where they get stored into the correct circuits in the brain, as well as with things like emotional regulation. And then over on the left, just with these overall body functions that I had mentioned, we know that sleep can be very important for promoting cardiovascular health. So not sleeping enough or not sleeping effectively has had higher rates of things like heart disease, for example. So, clearly very important. We don't know all the ins and outs of this. Somebody think, anyone would know just from their lived experience that if they are not able to sleep well, that it can have a fairly profound impact on their functional capacity. Brain circuits regulating sleep, as you can imagine, can be rather complicated. And so the reason really that I put this graphic up here is just to, show the extent of involvement, and that you could imagine that MS, regardless of any other symptoms, having MS lesions anywhere that impacted these circuits could certainly have a direct impact on sleep. So these figures are both what are called sagittal sections. These are like looking from the side, like the brain is in profile. And so the pink is all cortex or cerebellum, and then the tan color are deeper structures, including the brainstem. And so we see on the left-hand figure are more of circuits that are promoting sleep that will happen. And so you can see a lot of that is down in the brainstem. So as we work our way down from the midbrain to the pons to the medulla, all areas that are certainly prone to having lesions from MS. And then that red circuit on the right side are more of these what we would term like wakefulness circuits. So these areas can also be significantly impacted by MS among other disease processes. So just something to keep in mind as we think through what specific issues might exist with patients with multiple sclerosis. We all have circadian rhythms, which is an important just concept to keep in mind when we're talking about sleep and even sleep disruptions. So we have a couple things This is a fairly simple figure, but we have a few things that help to regulate our ability and drive to sleep. So two that are pointed out on here are melatonin. So we'll talk a little bit more about melatonin. I'm sure some of you take melatonin or some drugs that are similar to melatonin as some medications to help aid with sleep or sleep cycle regulation. So melatonin is released by the pineal gland. It can drive sort of this drive to sleep. You can see that it has a natural fluctuation where it is at lower levels during the daytime. Again, this is driven by sun exposure and light exposure, and then at higher levels, sort of in advance of the time that people fall asleep. So that is one driver that helps regulate things. And then the other, again, something that people have probably realized from their lived experiences is body temperature. So we tend to sleep better and have lower body temperatures or tend to sleep better with lower body temperatures. That can also be an influencing factor. So one, environmental thing that we may pop up for people is having cooler rooms to sleep in, for example. And so that certainly can be challenging, for MS patients who are already heat sensitive at times of the year, like now, where it has constantly been 10 to 15 degrees above the typical norm. But circadian rhythms are sort of our natural, drive to have sleep. So as far as how that works, we of course have light as an environmental trigger. When we look through this pathway, our eye, so the retina is like a wallpaper on the back of the eye that will sense light. It will create an electrical and chemical reaction, and then that signal will move into the brainstem through the optic nerve, and then that signal will then go back to the pineal gland, so highlighted there in green, sort of down in the base of the back of the brain. And then that light-induced activation will stimulate that melatonin production. So when you think about taking melatonin to help regulate your sleep, it is based in very strong biology, where we know that from animal studies and a variety of other experimental studies that melatonin is a critical part of this pathway. So something that often makes a lot of sense from a treatment standpoint, especially first line, which we'll talk about. So we all have different stages of sleep, which I'm sure people have experienced, and I think there are technical definitions for these things that are based on EEG, so brainwave activities, as well as some behavioral patterns. But these are important to think about just because they can serve some different functions. So there's really four stages that we'll focus in on. So there's three that sort of have kind of boring names of just non-REM sleep. We'll talk about REM sleep, which is the last stage on the next slide. But so stage one sleep is just when you're really transitioning from wakefulness to sleep. It's relatively light sleep. We start to see some changes with slowing on the brain waves, but ideally you will transition to more of what we would term restorative sleep in stage two and to stage three. So if we look at the definitions for stage two and stage three, we see more of this regulation of drop of body temperature. The brain waves on the EEG test are slowing, and then that is just more progressive and just more relaxation and harder to awake. So there is some degree of correlation to the deeper that you sleep, the more restorative that the sleep is going to be. So if there's things like medications, for example, or frequent awakenings, because you typically have to transition through these stages, those can be quite disruptive to people, being able to get restorative sleep. So whether that's things that are waking you up from pain or having to use the bathroom or sleep apnea, for example, all things that are really common for people that have MS. So rapid eye movement or REM sleep, so that usually is something that will develop over about an hour and a half after falling asleep as we progress through these cycles. So this is where, people will basically be paralyzed as far as skeletal muscle, but their eyes will be moving around. So that's how people get the name. And then the EEG actually starts to act up where the brain activity is, as opposed to just really slow lit waves can actually look more active. And so this is, again, an important component as far as when we're thinking about cognitive aspects and memory storage with sleep. This is a necessary stage. And so REM sleep is often also disrupted by certain types of medications. So we'll take a look at just sort of the progression of these things, and you can see why it might be harder if you don't have sustained sleep to get into REM. Is that typically it comes from a different, progression through these stages. So if we're not able to do that, we can spend less time in REM, which we typically would spend more time in REM over the course of the night, and that can limit us as far as having high quality sleep. I mentioned a little bit of this, but as we move from sleep biology just into the systemic effects or the effects on the whole body, we see a number of different organ systems that are involved. So I think it is really critical to have an understanding that sleep, if it's not good, it should be a priority, just because it can have a risk of a lot of different problems. So we see the risks of Alzheimer's, Parkinson's, dementia listed on here as far as in our graphic for the brain. There is certainly a risk of heart disease or CVD, which is showing increased rates of obesity, potentially increased rates of cancer, dysregulation of things like blood sugars and cholesterol, which is showing down in the bottom right, more mood disorders, and then immune system suppression with risk of infections. I think some of these things we all have experienced, like getting sick if we're stressed out and not sleeping, for example, but there can be some pretty significant, slow to develop consequences, and why this is something that we should always have on the radar in our clinic visits, just so we can help better address these things from a medical standpoint. So one way to at least get a generalized idea of if sleep may not be adequate, because there are some standards for how much people should sleep, but a lot of it is driven by how people are feeling, is this thing called the Epworth Sleepiness Scale. So I'll often ask my patients about this in clinic, just because it gives us a sense for, might there be a problem or not? And it can be filled out very easily, even for patients just on their own accord. So basically what this scale is doing is it poses several activities and then asks about the risk of just falling asleep. And so what you can imagine if that is that you're not getting enough sleep, you're going to be scoring higher on this scale as we move left to right, with higher chance of nodding off in these situations. And then the box is checked in each row, and then the score is added up. And then the higher the score, especially if it's over 10, becomes more concerning, that the patient is not getting enough sleep or not getting enough quality sleep. And so these are, fairly self-explanatory as far as running through. Some of them are, probably not too concerning in isolation, but if you start scoring high on several of these, or if they're ones like when you're driving a car and you have a high chance of nodding off, that always raises concern. And that's not to say that if you score really low on this, you do not have an issue with sleep if you're otherwise concerned about it. So it's still worth a discussion. It's more of a screening tool that is sometimes helpful for us. Okay. So as far as how sleep disruption and things might play a role from a neurology standpoint specifically, so this is a fairly complicated graphic. So we'll just talk about some of the basics with it. But this is not specific to MS. This is actually a figure, like I had mentioned previously, that there's been a lot of attention on sleep and Alzheimer's disease. And so if you look at the upper right hand of the figure, one of the reasons that this has become important is we think that some of these proteins, like the A beta or amyloid beta, and this phospho-tau that are shown over there, that those will build up more and potentially cause more injury, to the extent that those are related to brain injury when people are not sleeping correctly. And so we had mentioned part of that idea of clearance from the brain, so this idea of lymphatic flow. That's where abnormal or toxic proteins are typically removed from the nervous system, that process slows down if people are not sleeping adequately. We also think that some of these toxic proteins are increased in their production with increased neuronal activity, or how much the brain cells are firing. And there'll be more brain cells firing, more brain cells firing more frequently if there's less sleep happening, just because sleep is typically going to slow down the brain activity. So there's a number of other influences on this, including things just like aging, superimposed sleep disorders, other medical conditions like heart disease, environmental factors, so even things like noise and other stressors. But these things over time will lead to damage to the neurons and to the synapses, which are connections between our brain cells. They can lead to increased neuroinflammation, which is particularly interesting from the MS side of things, and then something called reactive oxygen species, which are felt to be another chemical that can injure brain cells. And all of these can lead to neurodegeneration or just damage to the nervous system. So complicated process, but sleep can impact a lot of the physiology in a negative way if there's not enough of it. Specifically to MS and that neuroinflammation piece, if we look at this graphic here, we think that if there's alterations in sleep, so deprivations, so not being able to sleep enough, that could happen with insomnia and be influenced by things like anxiety or depression. Sleep fragmentation, so especially from things like sleep apnea, which is very common in MS patients, and then other sleep disorders, so things like restless leg syndrome that we'll talk about, is that those can increase these stress hormone levels, so cortisol, epinephrine, norepinephrine, reduce the production of some of those sleep promoting chemicals that we talked about, including melatonin, and these can drive some changes with immune system activation, then downstream create these signaling chemicals called cytokines to be elevated, which then can again go and cause some damage through various mechanisms to the brain cells. So important to try to limit that arrow between sleep alterations into the immune system as much as we can, and reduce these stress hormone production as much as we can. And obviously we're not going to talk about every way that might be the case, but as far as sleep as a driver of that is an important thing for us to think about. So sleep in multiple sclerosis is a real issue. Up to 70% of people that have MS will report sleep difficulties, depending on the study and how this is assessed. It's likely much higher that patients will, ever have some sort of associated sleep issue. These assessments are often set up by who brings these things up to their doctors, for example, so we don't ask about it and it's relatively minor, although it may sometimes be bothersome, it may not be accounted for. So I would estimate, probably 100% of people have a sleep problem related to MS at some point during their disease course. This can be an enormous driver of symptomatic worsening. I'm sure a lot of people that are on the webinar have experienced their MS symptoms even on a day-to-day basis getting much worse if they have not slept. And we think of that as that with MS, there's just not as much sort of backup capacity in the system. And if we add a stressor like not sleeping, it's much harder to maintain the same level of function. And I think this is important because it helps explain some of these things with the disease, but it's also very treatable. We'll talk through just some general concepts from that standpoint, but then for specific conditions that people may have, these things are often very well managed with medications or other interventions. So this is while it may not be perfectly fixed, this is not something that should sort of run unabated as far as causing symptoms. So I wanted to focus in on probably the five biggest categories of things that I would term sleep disruptors for MS patients that we talk through in clinic. So the first one is insomnia. We'll talk through some technical definitions of what that might mean, but I really think of that as just trouble falling asleep or trouble staying asleep. And that can, of course, be quite disruptive. We'll talk about sleep apnea, so either something called obstructive sleep apnea, which is more common in patients with MS than in the general population, or something called central sleep apnea, which has a different mechanism. And some people will have both obstructive and central sleep apnea. We'll talk about restless legs syndrome, which is a common condition in a number of neurological diseases. We'll talk about sleep disruptions due to other symptoms, which is super important because a whole lot of other MS symptoms can also directly impact sleep. And then we'll talk about one that is sometimes overlooked is that sleep can be disrupted due to medications. So oftentimes medications that are used actually at times quite effectively to help with other MS symptoms can also cause some problems with sleep. So there's an important balance there to make sure that we're using those correctly and then potentially modifying how, when, and potentially what medication we're using depending on its potential side effects. So as far as insomnia, there's some technical criteria for this, which is what I will mention. I don't know that this is incredibly important to technically have to meet all the boxes, but these are things to, I think about as far as not just characterizing insomnia as like what you might see in like a movie or something where someone's deemed to have insomnia and they like don't sleep for like 4 days at a time. So really, when we think about insomnia potentially becoming problematic, is that it's happening at least 3 times per week. It's a chronic problem, meaning that it happens for more than 3 months. There's not clearly like an alternative cause for it, like somebody's taking a whole bunch of a medication. So this is supposed to be driven more so by the brain circuitry itself. And then that the symptomatic pattern is not just difficulty falling asleep. So if we look at the top row, there are a few different things that will show up. So part one aspect would be just difficulty going to sleep on a normal or appropriate schedule. So people that can have disorders with their sleep phases, for example, where they can only fall asleep at 2 a.m., that they wake up too early and can't fall back to sleep, that they have fragmented sleep or they wake up all the time, so difficulty maintaining sleep, or that they have difficulty just falling asleep or initiating sleep. And then there should be some component of a functional problem from this. Like if you never sleep and can't fall asleep easily, but you have no problems, then it is less of a concern. So things that show up on here, probably the biggest one would be fatigue, although I would say especially in our MS patients, the other thing that we often see insomnia or sleep difficulties in general as a huge driver of is these impaired attention, concentration, and memory, or what patients will often term being brain fog. So that's often quite important. So the first line intervention for people that are not sleeping well from this standpoint is always talking about optimizing sleep hygiene. So this, while it is in some respects simple and straightforward because it does not require medication or like a intervention like CPAP, which we'll talk about, it is not always the easiest to do in the 2025. Part of this is about trying to set a regular schedule. Your brain tends to do better when you wake up and fall asleep at the similar times, no matter what day of the week it is. Trying to get exercise, which is often difficult to get enough time for, but not to do it too late in the day, because that can sort of ramp up the nervous system and make it harder to fall asleep. Avoiding caffeine and nicotine, just because those are stimulants, so those can often make it more difficult to fall asleep. trying different relaxation routines. One that is especially hard that I would definitely relate to is having a room that you just sleep in and not using screens or smartphones like in your bedroom, for example. I think although is a great thought, I think that's often very difficult for people, and even trying to limit use of devices in the evening. So to the extent that you can do this, great. I think one trick that will often have people do is using like the different settings on their phone just to reduce blue light exposure. That can sometimes make sleep even more difficult if you have more blue light. So definitely having filtering is helpful from that standpoint. And then if you are struggling falling asleep, don't just sit there and stare at the ceiling. It's best to like try to distract yourself and do something different and then try to get back to sleep instead of just rolling around in bed. The sort of second line thing that we like to use, but does take a fairly significant investment for insomnia specifically, is something called cognitive behavioral therapy. So this has a number of different components. It often will focus on cognitive therapy and then these relaxation techniques to try to basically reprogram whatever circuit or part of the body is not allowing people to fall asleep in a more regular fashion. So the cognitive therapy piece, I like because it basically is trying to reprogram the thoughts that may drive you in the wrong direction, like when you're not sleeping well. So there's these things you can see examples of identifying these maladaptive beliefs and then sort of challenge them basically try to reframe things. So cognitive behavioral therapy does take a lot of effort, but it's often very successful and has some sustained benefits as far as people that struggle with insomnia, like sleeping much better. And then there's more of the physical piece and doing things like mindfulness and diaphragmatic breathing over on the other side. Of course, these things are often complicated by or supplemented with medications. So this is a little bit of an older figure of some common prescription and non-prescription sleep medications. So we had talked previously about melatonin, which is down at the bottom. So melatonin is often our first line. It helps with regulating that circadian rhythm or that drive to sleep. It's available as an over-the-counter substance. It's often quite inexpensive. So we often have our patients try melatonin. It typically does not have a tremendous amount of side effects. It can cause people to have some vivid dreams, and then it can cause some grogginess at times in the morning, although it typically is a pretty well tolerated and often worth trying. I do prefer that over a lot of the over-the-counter sleep aids that include antihistamines. So although it would be fine for most patients to occasionally take something like Benadryl or a product containing Benadryl, which is diphenhydramine, to sleep, the regular use of those medications can have some risk of causing cognitive problems, especially in older patients. So I really don't prefer to have those as a long-term solution. And then if I need to move to a prescription medication from a side effect profile standpoint, I tend to use a lot of the next drug up, which is trazodone. So trazodone is an old school antidepressant medication at higher doses. We typically will use lower doses of it, even on an as needed basis to help with sleep. Tends to be pretty well tolerated. And then there's the other prescription medications above that, so things like Ambien and then benzodiazepines, which have many more side effects, and then Ramelteon, which is a similar medication to melatonin as far as which pathway it works on. So there's a lot of options. I think like most symptom management in MS, there is often some trial and error and trying to balance side effects and things like that. But if you have trouble, with after sleep hygiene and maybe trying some mindfulness and other things, it definitely is worth talking to your primary care doctor or your neurologist about potential medications. So we'll move from insomnia to sleep apnea. So this is, a very common condition. not just in MS patients, but just in the general population, and is also very treatable as long as it's diagnosed. So there's two forms of sleep apnea that we, encounter frequently. One is obstructive sleep apnea, which is represented on the left side of the screen. And so this is like it sounds. So apnea just meaning a lack of breathing or oxygen flow. And then it occurs during sleep, and then it is physical obstruction. So this happens when tissue, especially in the soft palate, which we can see can basically relax and block basically the flow of air down into the lungs. And so this can cause a lot of issues with people stopping breathing. It's associated with snoring. It's associated with some other characteristics that we'll talk about that might help assess for risk. Central sleep apnea is a little bit less common, but this is a disorder where there's a dysregulation in the circuit that is telling your body to breathe. And so this is coming from a problem in the brain. This is something that can happen at times with MS just due to the circuits in the brain potentially being irritated by the inflammation. So as far as things that would be besides fatigue and so forth, that would be of concern that you may have sleep apnea or that it's worth talking to your primary care doctor or neurologist about. And again, this is a risk sort of screening score like that Epworth scale that we talked about, is this thing called the stop bang score. So you 100% can have sleep apnea, even obstructive sleep apnea, without having loud snoring, but that is one of the risk factors. So you can see that listed as the S and stop. And then the other things that are thought about are fatigue, so tiredness, people observing these apnea or like choking or gasping events, which is the O. Sleep apnea is strongly associated with high blood pressure, so it can drive the blood pressure higher just because of some changes in the tone in the blood vessels based on the oxygenation. That should always be considered, especially for people that do not have other risk factors for having high blood pressure. And then in part because of this being obstructive and having that tissue sort of closing in on the airway is more so the bang. So that body mass index being more elevated is a risk factor, being older is a risk factor, having a thicker neck just because of the amount of soft tissue there is a risk factor. And then based on several different anatomical concerns, being a man is also a risk factor. So certainly if you're worried you may have sleep apnea, it may help to run through this score and talk to your doctor about it. Fortunately, sleep apnea can be diagnosed, these days relatively easily, I think, for a lot of patients. And so this is really a graphic just demonstrating, the sort of the old school way, which is actually still quite useful in a lot of situations, which is on the right. But then where we're at with technology, including with smartphones, which is over on the left. The on the right side of the figure, this is a patient that is undergoing a sleep study in the lab. So there are clinics that will have these overnight rooms where people can go in and get monitored, and so this is the best way to get data. It's not strictly necessary for a lot of patients, but if people are worried about unusual symptoms or having a home sleep test that has not demonstrated sleep apnea, but they're still concerned about it, a lab study is the gold standard. And so this will typically have some of these sensors around the chest to measure the breathing. It will have a sensor to measure oxygen that is on the finger, just like a normal pulse ox. It will measure airflow in the nose, and then it will typically have an EEG to measure the brain activity, like we talked about, to measure the progression through different stages of sleep. So a whole bunch of data. This is a study that's typically monitored by technicians. They can make sure everything's working correctly and really understand what's going on with the patient. So clearly that is, pretty intense and resource intensive. With technology, these home sleep tests, there's a variety of different forms have become more popular. I think generally speaking, they're pretty good tests, but they're not perfect, but they're often a good first line, and we use these all the time in clinic for our patients, and often are able to diagnose them accurately with this information. So this one that is shown is called the Watch Pat 1. So this basically has a sensor that is that rounded thing towards the center of the screen that goes on the index finger that can measure oxygenation and something called peripheral arterial tone. And then it has a sensor that goes on the chest that can measure movements. And then it all gets integrated into a little wristband and then connects to the smartphone. And then this just gets sent off either to the clinic or like a remote monitoring company. And then sleep apnea can be diagnosed pretty quickly. So these are really pretty easy to do. So people do get diagnosed with sleep apnea. One of the reasons that this is important to know about is that it's actually very treatable. So there's two, major modalities, and then there's a variety of sort of other things that are used at times and variations of this. But they're different based on if someone has obstructive sleep apnea or more of this central sleep apnea. So CPAP, which is continuous positive airway pressure. So what this is doing, especially for obstructive sleep apnea, is saying that the airway is closing down because everything is too relaxed. So we're just going to force air in so that the patient can breathe in, which is the problem. And so that is what a CPAP is. So it just forces air into the system. A BiPAP, which is bi-level, has two settings. So this is for more complicated things, including for central sleep apnea, that basically can help push air and set pressures in different directions to allow people to basically inhale and exhale more easily. Both can be very effective. I think these often get a bad rap initially from people that feel like they're not comfortable with things. I think most of the time, once the settings get figured out and there's some troubleshooting with masks and things like that, patients tend to actually tolerate them and then actually feel way better because if you have severe sleep apnea, besides the fatigue, like people often will get headaches, the cognitive problems, all sorts of things. So often worth dealing with some of the troubleshooting to get these things working correctly in order to see the benefits. Um, Another common condition that can impact sleep besides insomnia and the sleep apnea is restless leg syndrome. So this has some pretty specific criteria that we like to ask patients about. So this, despite the name, it's less common, but it can actually occur in the hands and some other places, but it's predominantly a symptom that exists in the legs. So this is going to be defined as just a atypical sensation or a restlessness that happens mostly in the legs. It is typically made worse at nighttime and worse with rest, and at least temporarily it will improve with movements. And then is not better accounted for by something like muscle spasms. And then it causes some issues, like especially with falling and staying asleep. So very common symptom, happens with MS, happens with Parkinson's disease, happens on its own. So fortunately, restless legs is, very well treated with current medication regimens. We just have to be careful about which ones we use and how. So I think two things that we like to start with, really before putting people on medications, though, is thinking about did we do something that made this worse? And so there are a number of medications that are really commonly used, including antidepressant drugs like fluoxetine, which is Prozac, and tricyclic antidepressants, which we use actually quite frequently for our MS patients for things like migraines and nerve pains that can worsen or cause restless legs. It's always important if especially if there's a relationship of starting one of those drugs and then getting bad restless legs to think about. And then we also know that having iron deficiency or especially with low ferritin levels, can result in restless legs. So we should always be checking those blood levels if there's new restless legs diagnosis. Should those things not be adequate, We have a number of medications that are helpful for patients, some that people may be on for different things. So sometimes we'll try to select these meds based on what other symptoms the patients have. But the first line medications for restless legs that both because they work well and they're well tolerated are these medications that are called gabapentinoids. So like gabapentin and pregabalin, so Neurontin and Lyrica. And so those can be effective even with single doses at reducing restless leg symptoms. So we use those all the time in clinic, and then have some added benefit if people have nerve pain or muscle spasms or things that are also popping up during the nighttime. These medications are also better from the standpoint you see this comment about augmentation. So augmentation is something that can happen with a number of the other restless legs medications where people will take them in the evening and then they sort of help, but then the restless legs just sort of moves earlier and earlier in the day. And it just creates this vicious cycle of using more and more medication. So that happens with the dopamine agonist drugs, which are drugs like ropinirole and pramipexole, which are at the top of the list. So for anyone that's on those and feel like their drug is sort of wearing off, that may certainly be true. And gabapentinoids like gabapentin are probably a little bit better medication from that standpoint. So speaking of medication, there are a number of meds that we use that can cause some problems directly with things like insomnia. So the ones that are probably most obvious are the stimulant medications that we use to hopefully help treat fatigue. So modafinil and armodafinil, so Provigil and Nuvigil, at the Adderalls and Ritalins of the world that we also sometimes use for cognitive symptoms, and then amantadine. So because these are all medications that are ramping up parts of the nervous system, they can also, especially if they're taken later in the day, cause trouble with sleep. Delphampridine, which is Ampura. So, really helpful medication for a lot of MS patients with walking speed, but also can be helpful with other symptoms like fatigue and heat sensitivity. So that drug also can increase some brain cell activity, and so that can also cause insomnia. So my typical tricks for dealing with these things in clinic is with modafinil or Adderall or Ritalin is trying to make sure that patients are not taking the drugs too late in the day. So we typically try to not use those after 12 p.m. My trick with delphampridine, which should really be taken every 12 hours for maximum strength benefit, is just to have patients take one dose, so 10 milligrams just in the morning, see if that is helpful to get them through most of the day, and then just not to take the evening dose. It is fine to take less Ampura than is prescribed. It is not fine to take more Ampura or to double up on a dose to just take it once a day. That is probably quite dangerous. Steroids, typically are not used long term for MS these days, but for people that have a relapse, for example, and get high dose steroids or on tapers for some reason, or getting steroids with their infusions, like with Ocrevus. Those can certainly cause some shorter term sleep disruptions. And then some antidepressants can also cause some difficulties with sleep. So two that I just singled out that are otherwise good drugs are bupropion, which is Wellbutrin, and then fluoxetine, which is Prozac. And then I think, one other thing that is really important is thinking about what other MS symptoms might disrupt sleep. And so part of this is because it helps us pick specific medications for things. And then part of it is just that make sure that we try to treat these things overall. So neuropathic pain. That can often be worse at nighttime. Fortunately, some of the medications that help with neuropathic pain, like gabapentin or tizanidine, will also help make people fall asleep just because they're sedating. Muscle spasms, so similar idea. Those can keep people up and be quite irritating. So some of these drugs like cyclobenzaprine can be helpful also with sleep. Magnesium as a supplement over the counter is typically a good first line thing to try. Spasticity, so meds like baclofen, gabapentin can help with that. Urinary frequency, you're having to wake up frequently at night, which we would call nocturia. So that can be an enormous disruptor to sleep, both from MS-related bladder problems, but also for things like enlarged prostates. And so oxybutynin for the overactive bladder or mirabegron for the overactive bladder can be very helpful. We also use sometimes a medication called desmopressin, which just results in the body retaining more fluid. So if that's just an isolated issue of having to wake up frequently at night to go to the bathroom, desmopressin can often be quite helpful. Um, Anxiety can drive some problems with sleep. So, doing behavioral therapy or taking anti-anxiety medications can be helpful. And then the same is true of depression. But again, like we mentioned on the previous slide, we just have to be careful that we're not, using a med that somehow makes this worse despite trying to treat the anxiety, for example. So there's a whole bunch of other resources to mention besides just this webinar. So the MS Center team has their great publication called Informs, and so they typically will pick a topic to dedicate an issue to. And so there was a Informs that was focused on sleep a couple of years ago. So there's going to be a link in the slides there. And then there's some additional resources that I put on here, both that is more MS specific, so from the MSAA, and then from the National MS Society, and then just more general information on sleep medicine, which is from the American Academy of Sleep Medicine. So just some good places to get some additional resources. So as far as some concluding thoughts from my standpoint, so I'm very clear that sleep is an important aspect both of overall health and of brain health. Sleep disorders are more common and sleep can be disrupted in MS, either from direct impact on the biology within the brain itself or due to the impact of other symptoms. Like those things like nerve pain or using the bathroom frequently at night. Sleep issues in MS are often very treatable, but we typically have to, just put some effort into diagnosing them correctly. So that's where it's always worth, if there's any concerns, talking to your neurologist or your primary care doctor about any specific symptoms or problems that you have. Okay, and so that was all that I had for my direct part of things. We're going to take some questions if anyone has, put them in the chat, and then if you have other things that come up, there's my email. Please feel free to email me if there's any other things that you don't want to ask in the chat. But thank you so much for your attention.
Awesome, wonderful information, Dr. Wolf. Thank you. We did have a couple of questions submitted. You touched a little bit on this, but if there's anything else you want to add, we had a question about, can brain lesions themselves affect sleep?
So yes, absolutely. So it depends on, like any other symptom, on the biology. So where is the lesion? And then how damaging is it? So we know that certain lesions, especially in lower parts of the brain, so in the brainstem, and then a part of the brain called the thalamus, can directly impact sleep, especially with making people more sleepy or more have attention problems and things like that. But yes, for sure that can happen.
Why do intense Charlie horse leg spasms happen at night during sleep? And is there any over-the-counter preventative? And I know you mentioned magnesium. We also have a follow-up question about which magnesium supplement is best to take at bedtime.
Yeah, so from the magnesium standpoint, we typically recommend magnesium glycinate or magnesium oxide, 400 milligrams, and specifically not magnesium citrate, just because it has more of a laxative effect. So people will often take magnesium citrate for colonoscopy prep. So probably not a great thing to take on a daily basis, especially at higher doses. But magnesium oxide or glycinate at 400 milligrams is good. The Charlie horse sort of spasm thing at night is interesting. Part of it might be just trying to lay in position that might set off some things. There is also some evidence that sometimes some of these symptoms, actually with motor symptoms like spasms, might actually get worse with sleep as the body temperature cools. just, especially for people that have really pronounced spasticity, that we may see that the temperature actually allows the body to move a little bit better and sort of that will sometimes actually allow the spasms to get worse, which is sort of unfortunate. But there are some specific spasm medications that potentially would be helpful for that, that even could be taken just at nighttime.
Awesome. Would you add like a regular stretching regimen into preventative for Charlie horses?
Yeah, I think that that is often helpful. So we have a handout of stuff I did not add for spasms and restless legs. So trying to make some dietary modifications, stretching, and then people often with restless legs as well will take like a hot bath before going to bed, and all those things can tend to help.
Are there any negative effects if you take melatonin long term, as in for years?
Um, it probably is a little bit dose dependent as to if there's any issue, but it is a natural chemical that the body makes. I don't aware of any strong evidence that it would be harmful to be taking. The major challenge that we have actually with melatonin has more to do with the fact that because it's a supplement, it's not regulated very well, so it's often difficult to know, exactly like is the dosing accurate? Are you actually getting, pure melatonin, that sort of thing? So it is, typically worth like trying to buy from a supplement company that has some third-party regulation. But I'm not aware of any significant long-term side effects.
Do people with MS typically need more sleep than the recommended 8 hours?
Um, As a general principle, I am not aware that people would need more sleep just from having MS. I think the question is if there's more fatigue symptoms, even separate from sleep related issues from MS, or if there's more sleep disorders that might, like sleep apnea, that might make any given unit of sleep less effective, is would you then need more sleep to make up for it? And the answer to that is probably yes, but not, solely from having MS alone in the absence of any other issues.
It's a great nuance. Jumping back to the melatonin, are there withdrawal symptoms if a person stops taking melatonin?
Not that I'm aware of.
I've been told that oxybutynin can cross the blood-brain barrier and shouldn't be used long term. Is this correct?
So oxybutynin does have some long-term concerns with long-term use about cognitive side effects, and just because of it can act on the acetylcholine system, which is important in the brain. So we often will think about using mirabegron, which is Myrbetriq, as an alternative bladder medication if people are going to be on it longer term. Yeah, that's a good question.
As we talk about some of the rest of the questions, we had a request to put the slide on the sleep scale up again.
Sure, yeah. Just like this one.
Let them chime back in. Yes, that one.
Uh-oh, I can't see it anymore. I'm gonna go back to oops. I don't know why it's not showing up.
I've heard that taking vitamin D3 close to bedtime helps with sleep. Is there data that supports that?
So we do like to make sure people have adequate vitamin D, just in general for MS. We know that vitamin D deficiency is a risk factor for getting MS and seems also to be a risk factor for having more disease activity. I'm not specifically aware of a study looking at the timing of taking vitamin D during the day, as far as if that would help with sleep. I imagine just as a general MS symptom, like if you're vitamin D deficient, you're probably going to have more, issues with sleep disorders, but not aware of if it matters if you take it in the morning or at night.
Does acupuncture help with sleep apnea?
Acupuncture may help with some sleep symptoms. Is probably not going to be a huge treatment of sleep apnea itself. Especially with obstructive sleep apnea, the things that are going to matter are all more physical, or as so the biggest ones are trying to reduce how much soft tissue is there, so like weight loss, or limiting things like alcohol that can relax the musculature, collapse. But then, there is some component, no matter how much of those things you do or don't do, some people just have an anatomy as far as how their airway is set up that they just get sleep apnea, and there's nothing that they could ever do to prevent it. And in that case, the things like CPAP are critically important.
Sensory reactions to stimulus like bed sheets can cause burning pain. Is there a topical medication to help?
So yeah, I think in the MS sort of context for that is something we call allodynia, meaning that all stimuli, even if they should not be painful, are actually painful. So sometimes people will describe that with clothing or bed sheets or just normal temperature water, just so having that sensory stimulation in any sort can be a problem. That typically is something that happens because of damage to the sensory circuits in the brain, or especially in the spinal cord. And so I tend to not see a huge amount of impact from topical medications, although sometimes some things like capsaicin might be helpful. Those probably would just make the issue, I think, worse. The What we tend to prefer is more of the neuropathic pain medications, just because those are going to quiet down and hopefully help reprogram some of the pain circuits, especially in the spinal cord. And so those are medications like gabapentin or pregabalin, or carbamazepine, among many others that would potentially be helpful.
This person has at night experiences extreme heat, peripheral only, feet and hand. It is palpable, the heat and redness. There's heat and redness, and usually the treatment is just exposure to cold air. Can I assume that neuron damage propagates the homeostasis issues I experience, the heat in appendages?
It does sound like something that can happen as a presentation of neuropathic pain. Potentially, and that may also respond to similar sorts of medications.
What is the dosage for melatonin that you would recommend?
Typically, it comes in a couple different doses. I typically have people start taking 3 milligrams if we're going to recommend it, but it often is sold at three, 5 or 10 milligrams.
And last question for the evening. Thank you for the extra couple minutes.
Sure.
Does using gabapentin for a long time have any long-term negative effects, like cognitive issues?
So it's a good question. It's probably dose dependent. If you're using it for restless legs, it's typically a smaller dose, like 1 time per day. So I think of all the medications that we use in MS for symptoms, like gabapentin has the highest range of dosing. So I have people that take gabapentin 100 milligrams 1 time per day for restless leg syndrome. I also have patients that take gabapentin 1200 milligrams 3 times a day. So 36 times as much in a day for like chronic nerve pains. So certainly if there is a risk, it's going to be related to the dosing and that exposure as far as the side effect standpoint. There are a few studies that suggest that there may be some issues, especially with higher doses of gabapentin with cognitive outcomes. It's always a balance. I think I don't get particularly worried about low dose gabapentin, even chronically, especially if it's also helping people fall asleep, which we know is separately a risk factor for having cognitive problems.
Awesome. Thank you so much for all of this great information. Thank you, everyone, for your wonderful questions. And again, we'll send this recording out early next week. Have a
All
great
right.
night.
Thank you.